Hi everyone, it's Richard here to give us a recorded in-service regarding a program that will be rolling out in B22 very soon, and it is the IMBED program, which stands for Implementation of Best Available Evidence into Practice. The focus today is on incontinence-associated dermatitis, or IAD, which unfortunately we're seeing more and more of lately in the healthcare system. And the goal is simple: to understand what IAD is, how to identify it early, and how we can prevent it through consistent care. So this slideshow was given to me by Sudi at the Wound Care CNC here in Campbelltown Hospital, but it was made by the names that you can see there on the screen, and we will get into the presentation now. So by the end of the session, you will be able to hopefully define what IAD actually is, understand what puts our patients at risk, correctly classify IAD using the GlobeAid tool, and tell the difference between IAD and a pressure injury, and use practical strategies to prevent and manage IAD. So this isn't so much about theory, it's about real bedside practice that protects skin and integrity. So what exactly is IAD? It's skin damage caused by exposure to urine or feces, basically prolonged moisture and irritation. It falls under a broader umbrella called moisture-associated skin damage, or MSAD. MASD. The skin becomes red, sore, it might burn or itch, and for patients, it's not only painful, but it's also humiliating. So our job is to make sure that we don't let this happen. And you can see some different pictures of the different types of IADs on there to help sort of classify what you might see with your patients. So we will be trying to use this Globe Aid tool to help classify IAD. It's really straightforward. It's not a progression tool. It's just a way to guide our measurement. There are two main categories, each with an A or B subtypes. A means no infection, and B means infection is present. So let's break this down a bit more. Oh, okay. But before we break it down, we're just going to talk about the key risk factors. So who's most at risk? Think of the patients who can't move easily, have frequent incontinence, or rely on us to manage their hygiene. Moisture, friction, and occlusion are the big culprits. Basically, if someone's skin is staying wet or covered in layers, they're at risk. And remember, this can happen fast and sometimes within hours. Okay, so now we'll go over the classification of IAD. So category 1A is persistent redness without infection, just inflamed skin. Category 1B adds infection to it. That's when you'll see things like scaling or little pustules, usually a fungal infection. In darker skin tones, redness might look more purple, darker, or even paler than usual. So you've really got to know your patient's baseline skin color to help break down the categories of what you might be seeing in your patient. And here is a further breakdown of 1A and 1B. So you can see the different types there. That looks quite painful, both of them. So you can see 1A is persistent redness without clinical signs of infection, and 1B, persistent redness with clinical signs of infection. And now we come to category 2, which is skin loss. So category 2A is without infection, and category 2B is with infection. Often these will look weepy, shiny, or has the greenish tinge if it's bacterial. The main thing here is that this isn't just a sore skin anymore. It's now actually a wound, and therefore it needs a bit more of a wound care level intervention. And now here you can see an IAD on a patient with a different skin tone, which is something you may encounter with our ethnically diverse cohort of patients here. And now we'll be discussing linear lesions. So these are red or white streaks in the anal cleft area. They're often mistaken for pressure injuries, but they're not. These are caused by moisture and friction and not pressure. They're usually superficial, so they don't really require too much intervention apart from just keeping that area dry and clean and don't require an air mattress. IA IAD and pressure injury development. Now, IAD and pressure injuries are like bad cousins. They share a lot of risk factors. Once the skin breaks down from IAD, the chance of developing a pressure injury skyrockets. That's why early identification and prevention are so important. If we manage incontinence well, we're not just preventing IAD, we're also preventing pressure injuries too. Distinguishing IAD and from pressure injuries. This is one of the trickiest parts. They can look similar and they can coexist. The main difference is cause. IAD is from moisture exposure, pressure injuries are from prolonged pressure or shear. IAD is diffuse and irregular, pressure injuries are localized and usually over bony prominences. If you're unsure, treat for IAD and reassess after 3 to 5 days. The response to treatment will tell you what's what. Prevention and management. There are really two main pillars to prevent and manage IAD. One, manage the incontinence regularly with individualized toileting plans. Don't just hand out pads, actually get to know the patient's routine. Structured skincare, gentle cleaning, and barrier protection. It's all about proactive and not being reactive. So, some tips about managing incontinence, implementing individual toileting plans, like I said, ensuring a safe and accessible pathway to the bathroom, which can be presents its challenges in B22, but it is something we need to be aware of. Ensure mobile incontinent patients are allocated a bed as close as possible to the bathrooms, and use incontinence aids as a last resort. And this is just a slide about correct toileting position, which you can read in your own time, but I just conscious of time, so I'll keep moving through the presentation. All right, we'll be talking about SAP bed pads. So these will be replacing our blueies. The blueies will be taken off our stock, and these will be replacing them. So let's talk a bit more about them. We should only be using the super absorbent polymer pads, which is what SAP stands for. They will turn fluid into gel and absorb up to 50 times their weight, so the skin can stay dry. Only use them if the patient leaks small amounts at night or during wound drainage, and keep the layers to a minimum. A sheet plus one pad max. We shouldn't be putting patients in an incontinent pad and then a bluey underneath and then the bed sheet. We need to minimize the number of layers that our patients lay on. And this is just an example of what we're trying to avoid. So in this example, we've got a patient with up to 4 layers of the cotton sheet, the plastic sheet, incontinence pad, and the bluey. That just creates too much risks of friction and heat, and then just increases the risk of developing pressure injuries and other associated risks to our patient. Structured skincare regime, just some pictures and examples of things that we can do to help reduce the risks of IAD. And it's probably stuff that we already do, but just going over these pictures just to re-emphasize what we already do to make sure that we're compliant and then keeping our patients safe. And shown here is the recommended products to protect and restore the skin integrity of our patients. Again, I will be sending out this slide, this presentation to all of you as long as this recording. So if you did want to stop and pause and read through these a bit more, you're more than welcome to. And now an example of our less desirable products for our patients. So I think there is a bit of a long-standing culture, especially when I started this job, of using zinc cream for patients. But the problem is people were not using this appropriately. People are just lathering on very thick, which just leads to moisture being trapped in the skin and actually causes more damage. So just go through these slides and talks about the pros and the cons of the various products listed here. Management of fungal or bacterial infection. So if a patient has a skin infection in conjunction with an IAD, liaise with the medical team about how best to treat it. Use the barrier cream cloth first and then immediately apply any antifungal cream or powder. Clinical diagnosis is determined by visual inspection, and skin swabs are not used as the results are typically inconclusive or unreliable. So, in a nutshell, this is what IMBED is. It's assessing continence, regular toileting, consistent skincare, appropriate continence aids, minimal bed layering. If we get those five things right, then we can drastically cut IAD rates and improve patient comfort. And now we're just going to discuss the rollout of this program at Camden Hospital and just talk about the impact that it actually had over there. So at Camden, they found that patients were being put into pads even when they were continent. It was just easier. And then when audited 20 patients, every one of those that were continent on admission were found to be incontinent. So we changed the approach there. They introduced toileting plans, used SAP pads, and retrained staff. And the results, they got better skin integrity, fewer UTIs, and happier patients. It really showed that small, consistent changes can really make a massive difference. So this slide just talks more to about what I just said on the previous one. I'm not saying this ward does it, and I'm sure I haven't encountered that thus far, but I have definitely heard nurses in other facilities and other wards in this hospital encouraging patients to just defecate or urinate in their pads. That is not a, we should not be encouraging that sort of behavior with our patients. We should be making efforts to get them to the bathroom and maintaining their continence status, because once a particular section of patients become incontinent, it's very hard to retrain their bodies to go back to old habits. And this is just about the Camden audit results. And here we have just a summary of the project aim, which was to increase patient dignity, reduce IAD, and implementing appropriate incontinence products. And this slide just goes through the diver diagram template, which just shows the breakdown of the implementation of the project. And here we are talking about embed pad selection guide. So for our patients who are mobile, they should be put in this first sort of example here, where it's a net pad pants, which provide a bit more dignity, and it's not like the net pants that we currently employ here in B22. They do come in a variety of sizes, and they would be able to facilitate having a pad inside. So these should be used for our patients who are mobile, who are moderately incontinent as well. And then the slip pads, which we're currently in use, are for our bed-bound or chair-bound patients with moderate to heavy incontinence. The SAP pads for any incontinent patients based on clinical judgment. They have a 3 liter capacity to hold, various fluids, I guess. And then the last example there is a procedure pad, which can be used to do procedures if you're taking out an NG tube or, I don't know, a cannula, whatever, but these do not have a great absorbency. Mobile patients with light to moderate incontinence, just to go over it again, should be using the example displayed here. So I do have samples of these in my office if you did want to have a look at them or even try them on to get an idea of what the patients would be experiencing. Again, going over what said in that first sort of guide, bed-bound or chair-bound patients with moderate to heavy incontinence should be in these pads. I think we've all experienced when we've put mobile patients in these pads, these tend to slip down and they just present a higher falls risk for our patients. Any incontinent patients based on clinical judgments should be using the SAP pad when they're in bed, but they should not be using both. So you should not be putting your patient in the tabbed nappy and this underneath them as well. It's one or the other, just to make that clear. These will be the products that will be no longer recommended for incontinence management. We would probably have like a limited supply of these things, but we are trying to change the culture around the use of pads with our incontinent and continent patients. Again, going over what was discussed in a previous slide, these will be the procedural pads that can be used for procedures and not to be placed under patients, as these do not have a giant absorbent capacity at all. Just a slide explaining the different codes for the ordering process, and there's a breakdown of the cost as well. So you can see they come in small, medium, large, and extra large. Pretty sure we will just be ordering medium, large, and extra large at the recommendation of Sudi, the wound CNC here. Product codes for the slip pads, product codes for the SAP pads. And here we have a link to the Sway app that gives us a breakdown or just provides a resource for more information about all the things that we've discussed today. If anyone wanted to scan this or if they wanted more information, it's available via these links. I will discuss a bit more about what this means on the next slide. So here we have, you can see in that blue box is when Camden Hospital implemented this program. And this is actually the hack score regarding the UTI rates over time at Camden Hospital. So you can see once they implemented it, it dropped quite dramatically, which is not what people were aiming for, but it's just a positive outcome of implementing this system. Again, a further example of the impact of this program. And challenges and lessons learned. Some issues, there have been some issues around ordering products and having them available. It's been shown to save nurses time and some patients manage their own incontinence better. It saves waste with reduction in non-biodegradable products and increases continence awareness by making continence management part of the conversation. Cost comparison slide. A little bit of a breakdown about the rollout. It's already implemented in Camden Hospital. Some wards are already doing this in Campbelltown, and we will be the latest ward to roll this out starting very soon. And a reference guide for all the information that's been provided. So thank you very much, everyone. If you have any further questions or you want to know more, please send me either talk to me on the ward or send me an email, or you can always reach out to Sudi, the wound CNC here as well. And thank you very much for your time. Bye bye.